Good evening, everyone, and thanks for joining our men's health webinar. We're happy to have this opportunity to share this important men's health education with this group tonight. My name is Abby, and I'll be moderating tonight's program. I'm going to start by going over a few housekeeping items, and then I'll introduce our speaker. First, and most importantly, your participation is completely anonymous to our other attendees. No one can see your face or your name, or any questions that you ask can only be seen by myself and the speaker. We do encourage your questions and engagement though. So if you'd like to ask a question, please type it in the chat box at the lower part of your screen, and we'll save time at the end of the presentation to answer as many as we can. Tonight's webinar will be presented by Dr. Patrick Self, a board-certified prosthetic urologist and men's health specialist. Dr. Self, thank you for being with us this evening to share this important education with men in the Nashville community. I'll go ahead and turn it over to you to get things started for us.
Well, thanks, Abby. Thanks for the introduction. Yes, happy to be here. Always a fun topic for me to talk about, hopefully an educational topic for everyone here tonight as well. There's a lot of slides on here, and so I want to get started so we can try to get through them. But mostly I want to be able to leave some time at the end so that if there's any questions, there should hopefully be a chat box that y'all can see and type in any questions that you have. We'll probably reserve answering them for the very end, but feel free to type them in as you go, and then we'll get to them at the end and hopefully come away more educated on the topics we're going to talk about tonight. So I'm going to talk about a couple things. I'm basically going to focus on erectile dysfunction and stress urinary incontinence. But to give you a little background on myself, I'm from here in Franklin, grew up here, was away for a long time for training, but glad to be back in town. And my specialty is reconstructive and prosthetic urology. I did a fellowship at Duke University where we spent a lot of extra time focusing on those fields. Previously worked at the University of Alabama in Birmingham and was on faculty there, but then decided to move back home. So excited to be here and to be able to provide services to guys in the community with these problems. So we're going to start off a topic that I find very meaningful and fun to take care of because we have a lot of good help for men who are struggling with stress urinary incontinence. And I want to give a little background on it. So there's generally two types of incontinence. There's what we call stress incontinence, which we'll talk about tonight. This is what it sounds like when you're doing something stressful. You're coughing, you're laughing, you're sneezing, you're using the jackhammer, you're weightlifting, you're moving something heavy. When you do something stressful on your pelvis, it causes you to leak. Generally speaking, this is uncommon in men, unless you've had some sort of generally cancer treatment or some sort of trauma in the past, or maybe some sort of procedure that led this to happen. It's not usually something that's going to develop, say, just as you get older. Worldwide, about 13 million men have stress urinary incontinence. And in the United States, there's about 17,000 men every year who begin to develop a bothersome stress urinary incontinence. And we'll review some of the reasons why that might be. So the normal process for holding urine is such that we should never leak, whether male or female. And so in a man, you have your bladder, which holds the urine. And then we're sort of lucky in that we have two ways that the urine is held in our case. So there's a prostate, which has a sphincter muscle inside of it that we don't really control. It's one of the body's processes that it controls on the inside without us really having to think about it. And then there's a sphincter muscle that's below the prostate. This is one that we can actually control if we want. So if you imagined you needed to squeeze to hold back pee, that's this sphincter muscle. And then urine, if you're going to have leakage, it's bypassing that prostate and that sphincter, and then it's going out the urethra and leaking out. So when you have stress incontinence, that process is messed up. And really, there's no normal reason a man should ever have stress urinary incontinence. If this whole system is intact, guys won't leak. Okay, so the main cause we would see in the United States for stress urinary incontinence in men is prostatectomy. In this case, it's going to generally be prostatectomy for prostate cancer. That's what we call a radical prostatectomy. It's a bigger procedure. The whole prostate is removed, and we're doing this to try to cure the cancer. You could see this maybe less commonly after treatments for non-cancerous prostate procedures. So things like a TERP or maybe a HOLEP or maybe what we call a simple prostatectomy, things that are done for benign or non-cancerous obstruction of the prostate. We can also see it after certain spinal cord injuries or nerve-related conditions. We might see it after rectal cancer or some sort of pelvic radiation for not just prostate cancer, but even colon or rectal cancer. They can damage the sphincters that impact the bladder because they're very nearby. Rectum and colon sit right behind the bladder and prostate, so they can be injured. We also might see it happen with trauma. Maybe somebody's had a really bad car wreck or a fall or some sort of work injury where their pelvis was fractured, and that can cause damage to the sphincter muscles and how they work. So I would say, quite common for men to come in when they have this problem, and it's beyond just the leakage, that or wearing a pad or even wearing a diaper. There's a significant mental health aspect to urinary incontinence. I see many men who come in and say, I don't do anything but go to church for my 1 hour. I otherwise don't leave the house because I'm afraid I'm going to leak onto my clothes. They don't wear light pants anymore. They may not wear shorts anymore. They just wear dark pants because in case they have leakage, it's a little more hidden. I see people who travel, they bring an extra suitcase full of their diapers, if they're going on a big long trip. I can't imagine that's fun for anyone. And so it's not just the, getting your clothes wet. It's being stuck inside, and I think we all know that we're a social animal as humans, and we need to be out and we need to be doing things. And so it's not just, our clothes that's impacted, it's our mental health that's impacted as well. So when we talk about prostate cancer treatment, again, this is going to be the main cause of why men have stress urinary incontinence. If you look at the literature on it, prostate cancer is the most common solid tumor in men in the United States. So skin cancer beats it out, as an overall cancer. But if you look at an organ or a solid tumor, prostate cancer is number one. Thus, there are lots of prostate cancer treatments done, in any given year in the United States. So about 90,000. Of those men, you'll see anywhere, depending on the study you look at, about 9 to 16%. So maybe think 10% of men are going to have bothersome stress urinary incontinence a year after theirs treated. So it's quite common after prostatectomy or even not as much radiation, but a little bit radiation. Significant urinary incontinence right after treatment tends to get a little bit better as time goes by. But at a year, when we generally say you're probably done healing up from this, there's still about 1 in 10, 1 in 7 or 8 guys who's going to have bothersome incontinence that they are not happy about. So why does this happen? We alluded to this a little bit earlier. The prostate has these intrinsic nerves and sphincter muscles in it that you don't have to think about that help you hold your urine in. So when you get a prostatectomy and this prostate is cut out, well, that's gone now. And so now you're left with just that external sphincter, which doesn't show up in this picture here in the middle or on the right. But if you think back to that one before, there was that sphincter muscle under it. Depending on how good or strong that sphincter muscle is afterwards, will generally be a big impact on how your continence will be afterwards and whether or not you're dry. And the crazy thing about prostatectomies, you can do the same surgery on the first guy of the day and the second guy of the day, and one guy will be really leaky and the other guy won't be leaky at all. And it just goes to show you there's a lot of other things probably involved that we don't fully understand, but it's certainly something that we see after prostatectomy. So treatment options. I guess what I would say about stress incontinence is there's good and bad news about it. The good news about it is we have a lot of treatment options. The bad news about it, we don't have a pill, or an easy thing that helps fix stress incontinence. Because as we saw before, it's caused by surgery and it's an anatomy problem. It's not because we didn't eat right for a long time or our cholesterol is high or our blood pressure is high and we can take a pill and fix that. This is more of an anatomy problem. So what we'll sometimes see guys do when they have stress incontinence, commonly they come in and say, I don't drink any water. I don't drink anything because I know that the less I take in, the less I'm going to leak. Or what we might prescribe is, well, I tend to get leaky a couple hours, between doing things. So we'll say, well, I've told people to set the timer on their watch, or if you're watching TV, when it's a commercial break at the end of the show, make sure you get up and go pee. And that's just helping you empty your bladder. But that's work. That's a behavioral thing that you have to do all the time. Um, what we can do intervention wise is there are specialized pelvic floor physical therapists who can teach men and women, for that matter, if they have it, exercises that can help improve those sphincter muscles and muscles in your pelvic floor. What I would tell you is that if you're somebody who's maybe getting a prostatectomy soon or who's recently had one, what pelvic floor physical therapy can do, if you start it beforehand, you can learn these exercises. If you're just afterwards and you're struggling with leakage, you're not getting better as quick as you want to, going to see a pelvic floor physical therapist can help you regain your continence quicker. It doesn't necessarily make it better in the long run, but it can help you be drier sooner than you otherwise would be. And if you've got a urologist, if you've got a internal medicine doc, in our practice, we can make your referral. We know all of them around town, and we can send those in. Kegel exercises, think of that as like a home version of pelvic floor PT. The pelvic floor physical therapist will teach you a lot more than just Kegel exercises to help with leakage. But Kegel exercises is a sort of easy thing you can do at home. Biofeedback is essentially a fancy component of pelvic floor PT where they can teach you, hey, when you do this thing, it comes back and you get the feedback on it that says, hey, you did it right. And so it can be part of a pelvic floor PT program. And then, of course, probably the thing we see most commonly are pads, diapers. There's external catheters. There's penile clamps. Lots of different things, that can be done. These are obviously nice because they aren't a procedure. They aren't a pill. They don't really have. Shouldn't say they don't really have side effects, but their side effects are low. That being said, these cost money. People don't like to walk around with wet pads, and if they're real wet and they have to change them frequently, that can be a nuisance as well. So, like I mentioned before, unfortunately, we don't have a good medicine or pill for stress urinary incontinence. So, beyond those things I mentioned, this is a surgical problem. And, in the same vein, it's like, oh, I just had a surgery and I had this, side effect of incontinence from it. And now you tell me I have to have another surgery again. What I would say is that this Advance XP male sling system that we have is probably my favorite surgery to do. And obviously I'm a surgeon and I'm saying that, and I like doing surgery, but these are the things I think more men come out happy after this than almost anything else we do. And we'll talk about one other where it's kind of similar. But these people come in and they're like, they're high-fiving you and they're excited that they got this done. Obviously it's a procedure and you have to recover from it. But generally speaking, their quality of life is significantly improved, after this. So we use an advanced sling, at least in my practice. It's going to be for guys for a more mild to moderate leakage. It's going to be, if you've had radiation, you're not really a great candidate for this. The beauty of it is there's no moving parts. Once it's in, and it does its thing and it works. You never have to think about it again. The way the sling works, we list on here that it works as a hammock supporting and repositioning the urethra, and that's how we think it works. I think it's some people would argue it's one thing over the other, but what we do think it does is it probably, after prostatectomy or prostate surgery or trauma, your urethra falls out of your what we call true pelvis, and it's a little lower, and so this sling helps support it and lift it back up, but may also lengthen the part of the urethra that squishes to help hold the urine in. And so that's how this sling works. It's a quick sort of 30 to 45-minute outpatient procedure with an incision under the scrotum and then poke holes in the groin. And this little hammock of mesh hooks into the pubic bone there, and that's what keeps it in place and then stays there. You're drier when the procedure is over. And if you look at the bottom of the slide here, almost 90% of men would recommend their procedure to their friend. And if there was actually some studies done on incontinence procedures as well. 92% of men would generally prefer a male sling over anything else, basically because of the benefits of you get it in, you get it, it's outpatient, you're done, and you don't really have to think twice about it. There's another procedure that's called an artificial urinary sphincter. This is also a really satisfying procedure, just in terms of what it does for a guy's quality of life. This has been around longer than the sling. It's probably the original thing, surgically that we had out. It's been around since the early 70s. Um, and what this is slightly different thing. Rather than being a hammock under the urethra, it's a little cuff that wraps around the urethra and stays pinched off. So it was originally designed to help after prostate surgery for incontinence, but basically the device we'll use for any form of stress urinary incontinence in a man. Um, What's a little bit different about this one is that it's something you use. So that's connected to a little pump about the size of the end of my pinky finger, and it goes inside the scrotum. So none of this is visible. And that cuff keeps the urethra closed. When you want to go to the bathroom, you squeeze it, opens that cuff up, you pee, and then it automatically closes itself up. I'm generally going to tell people you're going to get 80 to 90% better, with either of these things. Um, so like I mentioned, the way this thing works is it's got some fluid that goes inside this cuff that wraps around the urethra. Think of this as exactly what it is, an artificial sphincter. So you had that sphincter muscle up there, doesn't really work that great anymore. Let's put this man-made artificial one in here. And then they connect it to this pump, which you squeeze, and then it draws fluid out of the cuff to open it up, sends it into this little balloon temporarily to hold it. And then after you're done peeing, the device is nice in that you don't have to do anything to turn it back on, if you will. It sort of automatically fills itself back up over the next 90 seconds or so. And that's what this balloon that goes in the groin area helps do. So there's a little animation here that shows how the fluid moves throughout the device. Oh, well, let me try again. So what we'll see here is the animatronic squeezing of the implant, the pump part of it that goes inside the scrotum. And then the fluid moves from the cuff, which is wrapped around the urethra in the back there, in the back of the screen. And then it goes up into this balloon, and then it allows you to pee. And so it's opened up here. And then when that fluid goes back in, it squeezes back down and squishes things off. So this is also an outpatient procedure. You can come in and go home on the same day. It's got a small incision underneath the scrotum as well, and then a little one in the groin area where we put that balloon in. I tell people to take it easy, usually a little bit longer than a few days, because we obviously don't want anything to go wrong with it. And then I have you come back in about 6 weeks, and we teach you how to use it. So a little bit different than the sling. The sling works right away. Artificial sphincter, you got to wait longer for that area around the urethra to heal up before we get you to use it. So if you look at artificial urinary sphincter, this one's been around a lot longer. So there's a lot of long-term published data on this one. So satisfaction rates very high, on the order of 90%. 90% plus would do the procedure again. And I commonly see this in practice in the sense that sometimes these things stop working and they break. These are the guys that are calling on the phone and saying, I need you to see you tomorrow because something's wrong with this and I'm leaky again and I want you to fix it. That's generally how happy people are. Again, very high satisfaction rates for recommending it to friends or family. And if you look at, how dry are you? I would generally tell you 80 to 90% better. I never promise anyone a home run, and get you completely dry. But if you look at this study, one pad or no pads, one pad, it's by the end of the day, or if you're doing something really stressful, you can still leak with any of these things. But 85% 4 years later, we're using one pad or no pads. So pretty, I'd say, successful device. So the good news about these things, generally speaking, they're going to be covered by insurance. It's pretty rare for me to find that they are not. Obviously, insurance unfortunately rules yours and my world these days in terms of what we can and can't do. So this is always something that we have to check, beforehand. But the good news, these are not considered cosmetic procedures. This is a medical condition generally caused by some sort of cancer treatment that you had. So these are usually going to be covered by your insurance. So we talked about the benefits of the device, in terms of risks. Generally, what I would tell you, the main things would be there's always some possible risks from a sling or a sphincter. These things can break or spring a leak, not so much the sling, but the artificial sphincter that's filled with the fluid. They can break or spring a leak and they stop working, and then we have to go fix them again. Very small risk of retention, so unable to pee after either operation. We usually deal with that with a short-term catheter if we need to, but I'd say pretty uncommon. There's always going to be the chance for a little bit of pain or infection at the site. The good news, you know, most of these guys, when they go home, they're not using anything beyond some, prescription strength ibuprofen or Tylenol type drug. Not common for men to be using, significant amount of opioids or narcotic pain pills. Okay, so quick summary: stress urinary incontinence, well-known side effect of prostate cancer treatment and some of those other cancers that I mentioned. We have a lot of options. I'm sorry that we don't have a pill. Maybe one day I'll invent one and then I can retire. But for now, we have surgical procedures. They're really good surgeries. I really like to be able to offer them because they are some of the happiest people that I have, and that's a very selfish thing, but it's true. And I think the good news is that the guys are generally happy as well, if not their partner too. So if you don't remember anything from what I said tonight, you could at least write down this website here, fixincontinence.com. You can go there. It'll have a lot of information about what I presented tonight. Urologist in your area, if it happens to not be me. And you can find hopefully some satisfaction and improvement in your quality of life if this is something that you're struggling with. Okay, so we're going to talk a little bit now about erectile dysfunction. So lots of different things that can cause erectile dysfunction. Obviously prostate cancer is one of them, but lots of other things we'll go over as well. So what is erectile dysfunction? Erectile dysfunction is the persistent inability to achieve or maintain an erection that is firm enough to perform sexual intercourse. How common is it? Very common. Yeah. So there was a big study done in Massachusetts back in, I think it was in the 80s. It might have been extended into the 90s, but they followed this group of people, this community of people lived in Framingham, Massachusetts, and they basically monitored their health conditions over an extended period of time, a decade, if not more. And what they found was that once you hit 40, roughly 40% of men are going to have some form of erectile dysfunction. It may be mild, but they're going to have a little bit. And that number just keeps going up as guys get older. So in your 50s and your 60s, you're going to see oftentimes 50% of the male population is going to have some form of erectile dysfunction. Younger ages, we see it too. I definitely see guys in their 20s and 30s. A lot of things to think about in that patient population. But as men get older, we'll review some of the typical conditions that cause it, and talk about treatment options. The good news: a lot of these things we can work hard, to try to prevent. So, how do erections work? Erections are, when we talk about this tonight, are purely the process of getting the penis hard. There's orgasm, which is that sensation of feeling good. There's sensation, which is just the physical sensation of touch. And there's ejaculation, which is the fluid coming out. These are totally different processes. So we're talking about erection tonight. So just keep that in mind when you are listening. So to get an erection, there are nerves that go around the penis that get activated usually when you're aroused by whatever's going on. What that does is it tells the blood that flows into the penis, the arteries, I should say, to open up. And so you see in the picture under here where it says flaccid, you can see just scattered, red dots throughout these corporal bodies, or the shaft part of the penis that gets filled. When an erection is to come along, these arteries dilate or open up, and now all of a sudden they're big and open, and the blood can get in and fill in these spaces. And then what happens is that fills everything up, and then these blue veins that are around the edge get squished by that compression from that artery blood flow flowing in. And that's what helps you maintain the erection. So the blood can't leak out, and then it stays erect. When you're done, with intercourse, then the erection, that nerve process reverses, the signal goes away, everything goes back down. So I think big thing, there's not one big cause of erectile dysfunction. I should say one condition, lots of things that can do it. Most of it, as you can see in the slide on the right, is vascular, which means it's a blood flow issue. So as you can see, we needed all this blood flow, to come in to make the whole process work. Diabetes is going to be the second biggest cause. And diabetes is unfortunately a double whammy. Not only does it impact blood flow, it also impacts those nerves that go around the outside. We often see it from medications. So medications for high blood pressure, for heart disease. These are common things that we can see to impact erections as well, because they lower, some of these things to lower blood pressure. They're keeping the ability of that blood to flow in there real nicely. But there's a lot of things that we do, as as humans, that aren't good for our erections. So, getting older is a contributing factor. Smoking, is a behavioral factor. Being overweight or living a sedentary lifestyle, not getting aerobic exercise is bad for your erections. In addition to some of these things that impact your blood flow, high blood pressure, diabetes, high cholesterol. These are the things that impact blood flow. So in terms of psychological effects, much like incontinence, see plenty of guys who are psychologically impacted, by this. Sex is an important part of their life, and it leads to anxiety, depression, low self-esteem. I've seen marriages significantly impacted, by it. So it can be an issue for a lot of people. And I think hopefully people can take away from tonight that we've got lots of different things, that we can do to help it, whether it's behavioral changes, or in this case, we do have good pills, or surgery as well. Okay, so just to touch a little bit more on diabetes. Diabetes, again, is a double whammy. Not only does it impact blood flow into the penis, it also affects those nerves. So perhaps some diabetics listening to this, or if they have family, have heard of peripheral neuropathy. You get the tingling in your fingers or toes. Or you can have stomach issues where the nerves in your stomach don't pump the food down right. Same thing happens to these nerves that go to the penis. So they don't work right, and they're not sending the signal like they should. And in some of those cases, that's a little more challenging. We don't have a great pill or medication, or even surgery for that matter, that makes nerves work better. So that's why diabetes can be a significant problem in terms of erectile dysfunction. We find that men with diabetes may be less responsive to our pills and our oral therapies, and it's again because of that the double whammy of having the blood flow and nerve issue. So I think one important thing to take out of this is that it's common for blood vessels to get a little tighter as we get older from high blood pressure, from being sedentary, from being overweight, from our cholesterol not eating right. And blood sugar, in the case of diabetes, can do it. So, what high blood sugars do is they damage the walls of the nerves and the walls of the arteries. They cause them to clog, or they cause them to not respond as well to these signals that are getting sent in. And in order for medications to work, in this case, erectile dysfunction medications, that signal's got to be able to get in. And if that signal can't get in, things like Viagra, Cialis, Levitra, they can't, work the way they're intended. So poor diabetes control, diuretic treatment, which is a blood pressure medication that we mentioned, heart disease, and the length of time you've had diabetes are all common things that increase the risk of erectile dysfunction when you have diabetes. Some type 1 diabetics, men who've maybe had diabetes from a very young age, it's quite common for me to see them in their 30s, and now they're really struggling, a little bit more because they've been living with it for decades. And so something to keep in mind, if you're a diabetic, really keeping the blood sugar under control so that you're not living in a high blood sugar environment for years or decades can really improve things. Okay, so how about heart disease? I think big takeaway here, heart disease, it's the same problem. So it's clogged arteries in your heart. When you have a heart attack, it's because a blood clot formed in a clogged artery and shut off the blood flow to the heart, and that caused you to have pain or shortness of breath. Cardiologist goes in, puts that stent, and opens it up. Well, the thing to know about erectile dysfunction is this is oftentimes a precursor or shows up before heart-related events. So maybe not as much in younger guys, but if you're an older guy watching or listening to this and you think you're healthy, but you have erectile dysfunction, I would strongly encourage you to make sure you're checking in with your primary doc and keeping an eye on your heart, because we see heart events happen in these men when ED is the first thing that shows up. And then some people would argue that you ought to consider erectile dysfunction a warning sign of heart disease. So and as you see down here, in 70% of cases of coronary artery disease, men reported having erectile dysfunction years before that. So this is a slide I like in this slide deck because it really shows what the problem is. Okay, so this is a coronary artery, representative size of a coronary artery. Obviously, it's not really that big, but this is your penile artery, smaller, than this coronary artery. This is your carotid, the one in your neck. And this is your femoral artery, the one in your groin that goes down to your leg. Okay, so you can see a penile artery significantly smaller than these other ones. This can impact stroke. This could impact blood flow to your leg and cause what's called peripheral vascular disease. But this is the one that's going to get hurt, when you have a heart attack. So you can see why ED might precede it, because it's a smaller artery. Okay, so what can we do to reduce the risk of erectile dysfunction? What's anything that's going to help blood flow and prevent that vessel from tightening up? So the things that generally do that were all that stuff we mentioned. So don't smoke, lose weight if you're overweight. We also know that aerobic physical activity is good for erection. So it mentions, exercising or physical activity. The thing I would stress is while weightlifting, is good for lots of things, for ED, you want aerobic activity. That's swimming, running, biking, a really fast walk. What you can think of it as, you're getting your heart rate up, you're consistently keeping it up, but you could still talk to your partner, say if you were going for a fast walk or a slow jog. If you're totally short of breath when you're doing it, you're probably working a little too hard in terms of aerobic. You're becoming anaerobic and it's not quite as good. Quitting smoking, alcohol is bad for erections. As you can imagine, drugs are, illegal drugs are bad for erections. Stress, is bad for erections. And then the thing we know we're all supposed to do, eat well. Heart healthy diets, Mediterranean diets, DASH diets, these things that are targeted for heart health or blood pressure are all generally going to be good for preventing or reducing your chance of getting erectile dysfunction. Okay, so how about low testosterone? I would say this is I think a condition that sometimes people confound the two. Low testosterone means I have erectile dysfunction. Erectile dysfunction means I have low testosterone. That's not necessarily true. Obviously we have to have testosterone as a man for things to function. Low testosterone can happen as we age. That's pretty typical. Obesity can do it. Bad diabetes can do it. Sleep apnea can do it. I see a lot of guys who don't use their CPAP, and they come in complaining of a lot of urology problems. And you need to get on your CPAP. It'll help your erections. It'll help you getting up and peeing at night. A lot of things that can help. Cirrhosis of the liver or kidney disease, HIV and AIDS, chronic opioid or narcotic usage is another reason that can make people have low testosterone. So what I would tell you is there's lots of symptoms of low testosterone. That's not really what I'm trying to talk about tonight. Erectile dysfunction is one of them, but the two are not, again, always present with each other. So generally, if someone comes in complaining of erectile dysfunction, I'm gonna check your testosterone. If your levels are normal, obviously that's not what's doing it. If we prescribe you some testosterone, that may help. But testosterone is not an ED drug. Testosterone can help with erectile function. It's usually got to be in the tank, for it to make a real big difference. But it can certainly be a component of the regimen that we use in men with erectile dysfunction. So how about prostate cancer? So we alluded to this before and its impact on stress urinary incontinence. Well, in prostate cancer, not only when we do surgery, radiation for that matter, to remove the prostate, those nerves that I talked about that go in to send the signal run immediately on the side of the prostate. Okay, so back in the 40s, 50s, 60s, 70s, when they were first doing radical prostatectomies, figuring out the technique and the procedure, every man who had this done was impotent. And then in the early 80s, Patrick Walsh, who was a chair at Johns Hopkins for a long time, has written a book that if you've had prostate cancer, been treated for it, a lot of people have read. He basically discovered these nerves with his colleague, and they created the nerve-sparing radical prostatectomy. And that radically changed the risk of erectile dysfunction after prostate cancer. However, it's still a risk. And so we try our best to peel those nerves off, but we're not always good at it, or there's injury to them, or the cancer is so bad that we can't spare the nerves. So if those nerves are gone or damaged, you never get that signal in. So you're just not going to get an erection without some help. Same thing too, as far as blood flow. It's not as much, messed up with prostatectomy or prostate removal. There are some people who have a different anatomy that can cause it to be an issue. But we think of it much more as a nerve related issue. So, similar picture to what we saw here, and that the prostate gets removed, but these nerves that run right alongside it are gone, and now they don't work the way they should. So when you look at erectile dysfunction after prostatectomy, generally I would tell you it's a much higher rate of this than incontinence. So depending on the study you look at, I would say a lot of people would say 2/3 of men who get a prostatectomy that's nerve sparing can recover their erections, but they may need some help. So if they didn't use any pills beforehand, they may need some pills now. If you were using pills or something more beforehand, you're almost certainly going to need something else to help you afterwards. We do most of the surgery these days robotically. There's nothing magic or special I would tell you about the robot that helps you have less ED. If you have a surgery coming up or a surgeon that you see and they do it an open prostatectomy instead of a robotic prostatectomy, there's not really any literature that supports one way is better than the other. Most surgery is going to be done robotically now because that's how we're all trained. The folks that do the open prostatectomies are all retiring, so there's not as much around. But I wouldn't necessarily seek it out in terms of erectile dysfunction prevention. Okay, so how about Peyronie's disease? This is another condition that can cause erectile dysfunction. This is actually caused by scarring or plaque, we call it, that builds up in that corporal body, that shaft part that fills up. So it has to fill up and stretch, with the blood. So if you have a bad scar in there, what happens is maybe one side fills up, but the other side doesn't fill up the same. And then what'll cause that to happen is things will turn. So this one gets nice and full, this one's stuck, and then things will kind of bend like that. And so most often we see it coming up or curving up towards the belly button. And this is a condition that unfortunately we have not amazing literature on what even causes it, which makes our treatment not amazing either. We've got a lot of stuff, and we have things that we can do, but this is a tough condition, for men, because oftentimes they don't know what caused it or why it happened. And I'm usually telling them, I can't magically make you back the same way that you were. The good news is we have some treatments. We will oftentimes use medications, so things like tadalafil or sildenafil, the generic forms of the ED drugs. There are medications we can inject into that scar tissue, and then in some cases, the Peyronie's disease will cause erectile dysfunction. And in this case, it's not just the curvature, but that side of the penis that has the curve can't fill up like it should, so those veins don't get pinched off like they should. And so oftentimes guys have a problem keeping their erection because those veins don't squish like they should. That's a hard problem for us to fix when the veins are an issue. So in some of those cases, really bad ED or bad ED plus curve, bad curvature, maybe they still got a little bit, some erectile function. These are cases where surgery is probably more likely what we're going to recommend. And especially when you have erectile dysfunction, these are when penile implants are generally going to be the mainstay of treatment. So we'll touch a little bit about those real quick and go over those. Main treatment options we're going to have for erectile dysfunction. Those behavioral changes that we talked about, controlling our blood pressure, exercising, stopping smoking, losing weight. We've got the pills, tadalafil, sildenafil. We have injection medications, which can be helpful, especially for guys with nerve issues. And then we have penile implants. I would tell you that we tend to oftentimes use pills first, but there's no order. We can use any of those things in any order anybody wants. Someone may say, some men might have a condition where they can't take pills, or they might be afraid of needles, or they have a condition where I know none of those things are going to work and we're going straight to a surgery. So there's not any right or wrong answer. It's definitely a conversation to be had, and I'd encourage you with your urologist or general medicine doctor, whoever takes care of you, for that. Make sure you're talking about all of those things so that you have them on the table. Penile implants are good options for the guys who have failed all those other things, or like I said, maybe have certain conditions where that other stuff just isn't going to work. And like I mentioned, it's not always just us, treating this. Lots of family doctors, lots of general practice doctors who deal with erectile dysfunction. I would just encourage you, try to find an MD, who specializes in this, or DO. What I mean is, a doctor or advanced practice provider, someone who this is their realm of expertise, not the things you see or hear on sports shock radio or the ads on the billboard, driving down the interstate, or that you see in Sports Illustrated magazine. I can tell you a lot of those places are just taking your money. Come see those of us where you got a cheaper copay, and we can make sure that we're touching base on all of these things that can contribute to your erectile dysfunction, and we can give a more holistic approach, to it. Folks like me, obviously I specialize in this realm and the surgeries that we do for it. So that's a lot of what's getting to me is when other urologists or family docs have tried these things and they're not working. It's time to move on to an operation, or some sort of injection, and they're headed this way. So I mentioned a lot of these different things before. I did forget to mention vacuum erection devices. These are devices that slide over the penis and help pump or pull blood into the penis, and then you put a little band around the base of it to hold the blood flow in. And then that is a way to help get an erection. We have the pills that we mentioned. Injection medications, these really bypass those nerves, that don't work right, and essentially inject medication directly into that part that gets rigid to bypass that nerve problem, get those arteries big and dilated and swollen so that the penis will engorge. And then there's penile implants when these things don't work, or they're not options, or men don't want to do it. I would, just highlight the bottom of this slide here. In addition to some of these medicines and behavioral things that we talked about, I would tell you that while psychogenic ED is not quite as common as people used to think back in the day, they used to think every man just it was all in their head, and now we know that's really wrong. Um, there certainly is that component of anxiety or depression or needing to work through something with their partner. And so sex therapists are specialists who can help you with that. We can make referrals for that. You can find them. There's plenty in the Nashville and Franklin area. So if that's something you feel like you need, it's worth looking up. Okay, so pills. What's great about them? It's a pill. You don't have to put a needle in yourself. You don't have to have an operation. They're a lot cheaper than they used to be, which is also great now. Common side effects I see from them, hands down, headache and facial flushing. Usually, if you can fight through the first 5 or 6 times of that and the medication's working well, that gets better. They can sometimes cause indigestion or nasal congestion. Important thing is to make sure there's a couple medicines, alpha blockers. That's like Flomax or tamsulosin. So a lot of guys in urology practice are on that. So you just want to be careful if you're taking both of those. You want to take them apart from each other, and you don't want to take them if you have nitrates for chest pain or you have to take that. That can cause an unsafe drop in your blood pressure. We talked about the vacuum device. What's great about it? It's sort of ready when you want to use it. There's no needles. You don't have to take a pill and wait 30 minutes. The downside to it, I say, very uncommon for men to use this as their long-term option. Where this band has to go around the penis here, this pinkish purple, band at the bottom, causes some hinging. People feel like the erection sort of bends unnaturally there. And then as you can even see in the picture, they feel like the penis gets a little blue or can even get a little cold, or uncomfortable because you basically cut off the blood flow after you've helped it come in. I tend to not see insurances cover these anymore. They used to when I was in training, and then Medicare stopped covering, 10 years ago or something like that, and basically everybody else followed. Tend to not find coverage for these. Injection medications are a great option if these other medications don't work or for some reason people can't take them. This works, like I mentioned, by essentially bypassing the problem, and you inject the medication directly into the penis. It sounds scary. It's not. I would say I don't have a lot of people who stop it because of discomfort with the injection. I'd say more often than not, it's maybe they're not comfortable with needles. It does have a risk of prolonged erection. So you see the commercials, an erection lasting longer than 4 hours, call your doctor. Well, that's kind of a nightmare for patient and doctor because that's a really bad problem. So sometimes the injection medications can cause that. We teach men to start with a very low dose and work their way up so that that doesn't happen. Problems with the injections, I'd say, uh, they have to stay frozen. They can be hard to travel with. A lot of times people pre-fill the syringes. And then it takes obviously you're kind of in the middle of, hey, it's tonight the night. Let me go get my needle out of the fridge and let it unthaw. Sometimes the spontaneity with the injections can be a downside for men. There also can be decently expensive, a bottle per se. Per injection, it may not be super expensive, but insurance, I've really never seen anybody cover this. So usually this is going to be a cash pay thing. Penile implants, these are a surgical procedure. So the way this works here is that there are two fluid-filled salt water filled implants that could put inside those corporal bodies that fill up. So we're essentially replacing those arteries and blood vessels in there with a pumpable implant. Just like the artificial sphincter animation that we saw, there's a pump that goes in the scrotum. You squeeze it, fills the implant up. Nice thing about it, it works right away. You don't have to think about waiting after the pill. You don't have to get your med out of the fridge. If the time is right, you're ready to go. And then it has a little reservoir shown in the picture here. This holds the fluid in it, that moves back and forth between when it's full or not full. When you're done with it, you push a little button on this pump here, and then all the fluid goes away. If you look at results on satisfaction rates, high 90s, and some of the studies numbers may be a little bit lower than that, but you're still looking at high 80s, low 90s percentage of men who are happy with the implant. And it makes sense because these are men who maybe nothing else worked for them, or they've tried and it worked for a while and now the pills don't work and then the injection did. Now they don't, now they're able to get an erection again. It's spontaneous. They're not having to think twice about it. They're generally happy with it. The same can be said for partners. There's actually studies on partners showing that their satisfaction rates are really high too. So the most common implant I would say that we run across is an inflatable implant. The AMS 700 or American Medical System 700, which is manufactured by Boston Scientific, is the most common implant generally that's done. It has these three components to it. Like I mentioned, the pump, fluid-filled cylinders, and the reservoir. It's designed to mimic a natural erection. I would say no one knows you have this thing in. If you have one, unless they're really looking closely, at your genitals with your pants off, they're not going to know that you have one of these in. So if you're at the Y or you're at work, this is not a visible thing. And what's great about it when it's flaccid, you're flaccid. Again, nobody knows that this thing is going to be in there. This implant's been around since 1972, 1973, or at least the original iteration. It's obviously gone through modifications. It's been around for a really long time. And generally been proven to work very well. Over half a million implants that have been put in. So this is an animation on this, and very similar to the artificial sphincter. Same guy invented these. So same concept in that there's a pump in the scrotum that you pump up, and then that draws fluid out of the reservoir in the groin area and fills the shaft up. So you can see in the animation they're pumping that pump. It's taking fluid out of the reservoir here and then filling these cylinders up. This thing's going to stay up as long as you want it to stay up. And then when you're done, there's another little button on the front there that you push, and then that fluid gets reversed and taken back into that reservoir. So nice thing about penile implant, they're generally also done on an outpatient basis. A couple different ways we do it. Generally, in my hands, you're either going to get an incision on the scrotum or an incision right above the penis on the pubic bone. And everything's put in usually through one incision. You go home the same day. You'll come back in about 6 weeks and we'll teach you how to use the implant. Similar to the artificial sphincter, generally I see that these are covered. There are some occasional plans where I'll see where there's a specific exclusion for surgery for erectile dysfunction. Not super common. So again, scenario where if you were going to do this, we would, check on coverage. I want to try to get through some of these slides here at the end so people have time to ask questions. But again, high satisfaction rates. 95% would do it again. 95% recommend it to their friends. 95% happy with sexual intercourse after they get these put in. I think I see a lot of what we see in these videos, and this is available on the ED Cure website. There's a list of 5 or 6 videos where you can follow the course of various different men who decided to do this and what their experience with it was. So you don't have to take my word for it. There's information here. And if you look me up on, the website, there's some more information that I have on there with links to other videos, that you can watch. But again, high satisfaction rates. They're generally very reliable. These devices last a long time. High 80s that are still working a decade after you put them in. Again, everything's on the inside. Nobody's going to know you have it. Like I mentioned before too, this only impacts your erection. It doesn't impact your sensation, your orgasm, your ejaculation. Those were different nerve processes and different things. Obviously, there's risks, just like there are with any surgery. The main thing I'd say we get scared of are infections. The good news is these are really rare. This device is coated in an antibiotic to prevent it. We talked about device malfunction. Maybe we have to do something to fix it. Unfortunately, if it does malfunction, it's usually going to be a surgery to fix it. And then rarer things would be erosions or migration of parts of the device. Those are pretty rare. So check out this website if you want to get more information, edcure.com. If you don't have time or can't remember the video series part, you can find it on there. Or you can text to this number here and that'll get you some videos, or you can scan the QR code here. And this information, we can double check with Abby here at the end, but I'm pretty sure it'll be available to everyone, after the fact. And so if you don't have time to scan it or write it down, should be able to be there later. Okay, well, I tried. I barely squeaked through making it to the end with leaving some time for questions. So I want to make sure I'm able to answer some questions that anybody has. And I appreciate everyone for spending time